Hello students, now today we are going to learn about the hip joint. Now hip joint is a multi-axial ball and socket type of synovial joint. The articular surface of the hip joint are a cup shaped acetabulum and the ball is formed by the head of the humerus. Acetabulum is a deep socket type and the cavity is again accentuated by the labrum present on it, that is called as acetabular labrum. Now we'll learn the ligaments of this particular joint. They are first and foremost is the capsule, then synovial membrane, the acetabular labrum, iliofemoral ligament, pubofemoral ligament, ischiofemoral ligament, and the transverse acetabular ligament. Here I would like to tell you that the transverse acetabular ligament is nothing but it is a part and parcel of the acetabular labrum, which is bridging the acetabular notch. Now the capsule, it is strong and thick and it is attached on medial side and the lateral side. Medially it is attached to the margin of the acetabulum and laterally, anteriorly it is attached to the intertrochanteric line of the femur and posteriorly approximately 1 centimeter proximate to the intertrochanteric crest. Now the synovial membrane, the extensive synovial membrane within the capsule is there and which lubricates the joint and it allows the free movement of the joint. Now the iliofemoral ligament. Iliofemoral ligament is one of the strongest ligament of the body and this particular ligament it is inverted Y shape having the apex is attached to the anterior-inferior iliac spine and the base to the intertrochanteric line. It prevents the overextension while standing and prevents the trunk from falling backwards. So we need to know over here or we need to understand that this is the one of the strongest ligament of the body and it is Y-shaped. Now the next ligament is the pubofemoral ligament. It supports the joint inferomedially. It is triangular in shape and it is having the attachment. Superiorly, it is attached to the iliopubic eminence and inferiorly, important to note that it merges with the capsule and the lower band of the iliofemoral ligament. Okay. The next, the ischiofemoral ligament. It reinforces the posterior aspect of the fibrous membrane and medially it is attached to the ischium and laterally to the greater trochanter deep to the iliofemoral ligament. Now the next one is the ligament of teres. Now this ligament of teres is also known as ligament of head of the femur. It is round in shape and it it more important that it transmit arteries to the head of the femur, okay, and it is engaged in the nourishment of the joint. Now we will study the relations of the joint. They are studied as superior relations, inferior, anterior, and posterior relations. Now, what are the anterior relations? The anterior relations are the straight head of the rectus femoris, then the tendon of the iliopsoas, and the pectineus. Okay, the pectineus. Apart from them, there are certain structures which are femoral nerve, artery, and the femoral vein. I repeat it again. Anteriorly, it is related to the straight head of the rectus femoris. Then the second muscle is the tendon of the iliopsoas and the pectineus. Apart from that, the vessels and nerves are there, femoral vessels and the femoral nerve. Now, posteriorly it is related to the piriformis, then sciatic nerve, obturator internus with the two gemelli, chordatus femoris and the gluteus maximus. Superior relations are the reflected head of the femoris, gluteus minimus, gluteus medius, and the gluteus maximus. And inferiorly, it is related to the pectineus and the obturator externus. So these are the relations of the hip joint. Now the bursae around the hip joint. They are round trochanter. Okay, so which basically when we are sitting, it lubricates and acts like a cushion. So apart from this particular bursa, another important bursa are the which are deep to the gluteus medius, then iliopsoas bursa, superficial to the trochanteric bursa, deep trochanteric bursa. These bursas around the hip joint, they facilitates the movement, smooth movement of the hip joint. Now, blood supply. Blood supply is mainly by the medial circumflex femoral artery and the obturator artery. This medial circumflex femoral artery, the vessel and the lateral circumflex femoral artery, they gives rise to the vessels which are passing around the capsule as the retinacular fibers to the this particular joint. And the obturator artery, it gives the branches to the ligamentum teres as mentioned earlier. So here we need to know the two important arteries are engaged in giving the blood supply, the circumflex femoral arteries and the obturator artery. Nerve supply. The nerve supply is by the femoral nerve, okay, then anterior and posterior divisions of the obturator nerve, now to the quadratus femoris, sciatic nerve and the superior gluteal nerve. Dear friends, here we need to understand the Hilton's law. What does the Hilton's law suggest? The Hilton's law suggests that the nerve supplying to the joint also supply the muscles moving the joint and the skin covering the insertion of these muscles. So two important things we have learned over here, that the number of nerves related or the engaged in giving nerve supply are more in over here, and they are also supplying to the skin and muscles above that particular joint, which is following by the Hilton's law. Now the movements are the this is the flexion, then extension, adduction, abduction, lateral rotation and medial rotation. Now these movements are executed by different muscles. These muscles are either the chief muscles first and foremost, and the supplementary muscles are the accessory muscles. Now the flexion is done by the psoas major and the iliacus primarily, and the supporting muscles are the uh, these one pectineus, rectus femoris, sartorius, and the adductor longus. Extension is basically done by the gluteus maximus and the hamstring group of muscles. Okay, these are the hamstring group of muscles. So the extension is done by the gluteus maximus and the biceps femoris, semimembranosus, semitendinosus, and the adductor magnus, ischial head of the adductor magnus, which are categorized as the hamstring group of muscles. And the accessory muscle over here is the gluteus medius. Adduction. Now, adduction is done by the adductor longus, brevis, and the magnus. These are the adductor group of muscles, and it is supported by the pectineus and the gracilis. Abduction is done by gluteus medius and minimus and supported by the sartorius and the piriformis. So I repeat it again. Please do understand that the abduction is done by the gluteus medius minus and the tensor fascia lata. Here we need to understand the gluteus maximus is not an abductor. Medial rotation is done by the tensor fascia lata and the anterior fibers of the gluteus medius and the minimus. And the lateral rotation is done by the obturator internus, externus, and the gamellae muscles. And it is supported by the piriformis. Okay. Now we will learn the clinical importance. In the clinical importance, the first and foremost is the dislocation of the hip joint. Now the dislocation could be congenital or it could be acquired. When I say it is dislocation, it depicts that it is the head of the femur is moved away from the acetabulum. Then second condition is the Perthes disease. Here, the gap between the acetabulum and the head of the femur is increased due to the flattening of the head of the femur. And the third one is the fracture neck femur. In the fracture neck femur, see, the fracture neck is of three types. One is at the just below the head of the femur, that is called as subcapital fracture. Then another one is just at the base of the neck of the femur, that is called as basal, and in between the two, the one more is that is called as cervical. Amongst the three, I repeat, the subcapital fracture is most dangerous. We need to note over here that the subcapital fracture is most dangerous amongst the subcapital, cervical, and the basal. Thank you so much. Now go to our MJMS classroom and solve the quiz related to this particular topic. Thank you.